Does it work or even though
All right, so let's go ahead and do E&M. So question number one, we're gonna only be talking about leveling at this point for this question. So a patient is seen for hypertension. Her provider has her on prescriptions, but her blood pressure is not yet at goal. The patient does not exhibit any symptoms. So when referring to the number and complexity of problems addressed, that's in our MDM table in the E&M guidelines, what type of problem is this going to be considered? So hypertension, they're on prescriptions and her blood pressure is not yet at goal. So with our number and complexity of problems addressed, which is your second column in your MDM table.
oh, it's stable chronic illness.
Okay. Yep. Is it stable? So it's
Oh,
a chronic illness for sure. Is it stable if they are not yet at goal? Even though they're not exhibiting any symptoms, we have to consider the big picture of, are they at goal? So is that going to be considered stable or is that going to be considered a progression?
probably a progression.
Yep. Yep. So if they had their blood pressure at goal, then it would be considered stable. Okay. So it's not a matter of exhibiting any symptoms, but like I said, because those blood pressure readings are not at goal, then it can't be considered stable because it's not under control. Does that make sense?
So like, what exactly did you say? Sorry, I got a little distracted.
So if it's not yet at goal, then that means that it's not under control yet. So therefore it can't be considered stable. Same thing for if we had patient has diabetes, and their blood sugar readings are not at goal, or they have elevated blood sugar readings or something along those lines. If they have an elevation in those blood sugar readings, that wouldn't be considered a stable condition, right? Because their blood sugars are fluctuating and they don't have control over their sugars. So be careful not to read too much into the sentence that says that they are not exhibiting symptoms, because even if they're not exhibiting symptoms, it's not controlled because those blood pressure readings are not at goal. Okay. All right, let's look at number two. A 32-year-old patient sees Dr. Smith for a consult at the request of his primary care provider, Dr. Long, for an ongoing problem with allergies. The patient has failed Claritin and Alivert and feels his symptoms continue to worsen. Dr. Smith performs a medically appropriate history and exam and discusses options with the patient on allergy management. The patient agrees that he would like to be tested, possibly to gain better control of his allergies. And Dr. Smith sends a report to Dr. Long, thanking him for the referral, and includes the date and the patient, or I'm sorry, includes the date that the patient is scheduled for his allergy testing. So Dr. Smith also includes his findings from the encounter. So we have to look at two things with this question. We have to look at multiple things really. First thing we have to look at is, what is the type of the encounter? Is it an office visit? Are they new or established? Or is it a consultation? Have they met the 3 R's for a consultation? Does everybody know what I'm talking about when I say the 3 R's?
Continue on North MacArthur Boulevard for 3/4 of a mile.
Consult. Oh, I can look them up right now.
So the 3 R's for a consultation. Does anybody know what the 3 R's are in order to be able to report a consultation? So if we go look at the codes for 99242 and 99243, that's where our consultation services start. So we have 3 R's. So yep, refer, or a referral is one.
request.
Well, request and referral are going to be the same thing. Yep. And then we have to render the service. So they have to actually give a service. And then the last R is they have to write a written report. So request, render, and report. So with this question number 2, do we have all 3 R's? So we have our request of the PCP. They have rendered it because he did his medically appropriate exam. So that's just going to be our render. And then he sends a report to Dr. Long thanking him. So that's our 3 R's. So with that information, we know it's going to be a consultation code and not a regular office visit. So we can rule out the 99203 and the 99214. Okay. So the difference between the 99213 and the 99242 and the 99243 is going to be our level of medical decision making, correct?
Correct.
Okay. So we have to figure out our level of MDM. So let's go back to our table, our MDM table in the guidelines. So first, our number and complexity of problems. What is our condition?
Allergies.
Okay. So the ongoing problem with allergies. So we have allergies. They have failed Claritin and Alivert, and his symptoms continue to worsen. So which level of number and complexity of problems addressed do we have? Is it a acute or a chronic illness? So that's the first thing that we have to think. Okay, Dawn says chronic condition with progression. What is your support for the progression, Dawn? If you want to just, you can either type it or come off mute, whichever one you want to do. Doesn't mean you're wrong. I just want to hear thought process.
I don't know. I guess an allergy could be considered acute allergy, but it's got, because I think the patient's having allergic reactions to the medicines, or it's just not. I just don't know.
So your thought process is going in the right direction.
It says Claritin failed.
Yep.
Aldivert,
Yep, because they failed the
Aldivert,
Claritin.
heart failed.
Yep.
Yeah.
And the symptoms continue to
got
worsen.
worse.
Yep.
Yeah.
So that's going to give us a chronic condition with a progression. So what level of number and complexity of problems do we have? So minimal, low, moderate, or high?
I think it's moderate.
Okay.
And it's
Yep. Yep.
well,
so
on my
moderate.
chart, on my medical decision chart that you you sent to me.
Yeah. Mm-hmm.
It says 1+ chronic illness with an exacerbation, progression, or treatment side effects.
Yep. So that gives us a moderate number and complexity of problems.
Yeah. Yeah. That's under moderate. Okay.
Okay. So then let's look at our amount and complexity of data. Okay. So with our amount and complexity of data, we need to look at tests that have been ordered, tests that have been reviewed, if there's an independent historian, if there's independent interpretation of tests, and if there's discussion of management or test interpretation. So did we review any tests?
No, just a test has been ordered.
Yep. So we agreed to do the allergy testing. Yep.
Yeah.
So what level of amount and complexity of data are we going to have for the one ordered test?
Low.
Okay. So if we have one single test that's ordered, so our minimal or none is 1 point between test ordered and test reviewed. The limited is going to be 2 points in a category 1. And then our moderate has to have 3 tests that are reviewed, ordered, independent historian, anything along those lines. So if we only have 1 point, what is our category of amount and complexity of data to be reviewed?
I'm
Okay,
assuming.
Dawn.
Oh, sorry.
No, you're fine. I was just gonna ask Dawn. She has in the chart, or she has in the chat, 2 points. Where's your second point, Dawn? I'm just curious.
Well, he ordered the test. He's going to review the test and go over with the patient, the
So,
results.
Okay, so I'm glad you said
That's
that,
what I'm thinking.
because if we order a test, we are going to assume that they're going to review the test with it, so you can't count that twice. So if the test is ordered that day and then they review it, then the review is going to be inherent within that order. So we don't count the review separate. No, that's totally fine. That's something that a lot of people mix up. So I'm glad you said that so that I could make sure that we talked about that. So we do only have 1 point. So that's going to be minimal, right? Daisy, were you going to ask a question just a second ago, or were you going to say minimal?
Oh, no, you explained it.
Okay, good. Good. I just wanted to make sure, because I know you were starting to say something, so I didn't want you to feel like I cut you off and then I wasn't going to let you come back on.
Oh, yeah, it's okay.
Okay. So we've got a minimal amount and complexity of data. Okay. So next we need to figure out our risk of complications and morbidity. So for our risk of complications and morbidity, what do we think with the testing that's going to be done? What level of risk of complications do we think will be there for allergy testing?
I would say 0.
Because it's just allergies.
While it is just allergies, there's always that minor thing, right? So minimal risk is going to be if basically they send the patient home and tell them to rest. They tell them to put ice on something, to put heat on something, alter, just gargle salt water, things along those lines, right? So for allergy testing, they're not just sending them home and telling them, well, just get over it, right? With lack of better words. So with allergy testing, there's going to be a low risk of morbidity because the chance of something happening is very, very low, right? But it's not almost non-existent. There's always that random chance, right? Whenever we're putting something into the body, like the serums that we use to test for the allergies, there's always that random chance that something could go wrong. They could go into anaphylactic shock. They could whatever. The chance of it is happening. The chance of it happening is very, very slim to none. But that chance is still there. So that's going to be a low risk because we're not just sending the patient home to manage it themselves, essentially. Does that make sense?
Yeah, makes sense.
Okay. So let me pull something else up here real quick. And then I'm going to copy it into here. I meant to have this pulled up earlier. So if we have, here we go. So if we have a moderate number and complexity of problems. We have a minimal amount and complexity of data, and we have a low risk of complications. What is our medical decision-making overall level? So we have to have two components in order to report our medical decision-making. So I've got some answers in the chat. I've got two answers that say low. Does everybody think it's low? Does anybody think it's different?
I'm still thinking straightforward.
Okay. So Dawn, yeah, there's two ways that you can figure out our medical decision-making from here. Okay. So you can either drop the lowest, which would be our minimal or none. Okay. So I'm just going to drop this. And our lowest one now is low, right? Or you can say we have to have two components that meet or exceed. So technically we don't have a column that has two components in it, right? There's one in each one. However, if we have enough to meet moderate, we have enough to meet low and minimum. Same thing, if we have enough to meet low, we have enough to meet minimal. So now we do have a column that has two, right? So that gives us a low medical decision making. Does everybody understand that concept? So you can either drop the lowest, like we did here. Oh, I went back too far. Nope. So we can either drop the lowest, right? And now we have a low because that's our lowest amount that we have there. Or we can move because we have enough to meet moderate, we have enough to meet low and minimal. And then that gives us two and that. So we're going to have a low medical decision making.
Okay, yeah, I'm still confused, but I don't want to hold up the class. But basically, there's just not enough for straightforward, like not enough evidence. Is what
Well,
you're
there's enough for straightforward, but if we were to code for a straightforward medical decision making, then our provider would get underpaid.
Yep, you're right. Okay.
So which
So we
code
want to
was
make
it?
sure. Well, hang on, I'm not there yet.
Oh, sorry. Sorry,
No,
my
you're
bad.
fine. So we want to make
was a
sure
little
that our
distracted.
provider is getting paid, right,
Mhm.
for what the service is, for as much as they did, right? You
Yep,
wouldn't be
that makes
happy
sense.
if you went to work and got paid $50 less on the hour, right?
Yeah,
that
yeah,
that would
makes
not
sense.
be fun. I would even be happy if I got paid $50 an hour to make $50
Yeah.
less an hour.
Yeah.
But we know providers do get paid that much. So we want to make sure that we're giving them the $75 an hour for the work that they did. Okay. So that's why
Okay.
we always want to look at it from an overall standpoint. So we have a
That's
low
good.
medical decision making. Okay. So let's flip back to the 99242 and the 99243. And what code is going to represent a low medical decision making?
99243.
Yep. So our 99243. Okay. We'll have plenty of other examples to go over it, but on this specific example, is that makes sense why we pulled what we've pulled out, and then we'll go to another one and kind of apply the same knowledge again. Okay. So for number 3, we have Dr. Howitzer sees Mrs. Jones in Clinic 8 for a sudden loss of consciousness while watching the Olympic torch go by. He is a new provider to the neurology department. Dr. Drake Rinaldi, a prominent member of the neurology facility or faculty at the university, saw Mrs. Jones last month. Dr. Howitzer performs a medically appropriate history and exam and the medical decision making of high complexity. And then our final diagnosis of transient loss of consciousness. Patient makes a follow-up appointment to see Dr. Rinaldi in 1 week. So what is our appropriate E&M code for this visit. So this example, okay, they actually give us our medical decision-making level, right? So some of your codes or some of your scenarios on the exam, they might, I don't want to say will, but they might give you the automatic medical decision-making, okay? What they're looking at is they want to make sure that you're picking the correct code to go with it. So we see 99203 and 99202, which are for new patient office visits. And then our 99214 and 99215, which are for established. So for this Dr. Howitzer, are they going to be considered a new patient, or is Mrs. Jones going to be considered an established patient for for Dr. Howitzer? Okay, Xenia, why do you think it's going to be established? Again, just because I ask questions does not mean you're wrong. I just want to hear thought processes.
Because it was a referral to this new provider.
Not necessarily a referral, but because they've
does the
seen a
doctor-
neurologist in their
The
university
same
within the last month.
Okay.
Yep.
So
because they were an established patient with that practice,
less than
and
3
Dr.
years ago.
Howitzer, yep.
Mm-hmm.
And since Dr. Howitzer is the same specialty as Dr. Rinaldi,
Mm-hmm.
then they're going to be considered established.
And that it was within that 3-year period as well, correct?
Yep, absolutely.
Okay.
Yep. Now, had she seen Dr. Rinaldi 4 years ago,
Then it'll be
then it would be new. But
Right.
because she's not new to the practice with that specialty, then
Neurology
you're
department,
going to
okay.
be established. Yeah.
Okay.
Okay.
Makes sense.
Perfect. Like I said, just because I ask a question doesn't mean you're wrong. I just want to make sure that your thought process is there
No,
to back up your choice.
No, it's good to ask because then
Good.
you can at least
Yeah.
make sure that you're doing that correctly.
Yep. I
And
have
your
a lot of people that
assumption
are
is
like, well,
correct.
I don't know. Why are you asking me that? And I'm like, because you can always just guess,
Yes,
So,
exactly.
exactly. So I just want to make sure. And like I said, I'm not picking on anybody if I ask.
No,
I just want to
I appreciate that for sure.
Okay. So we are an established patient. So we're going to rule out the 99202 and the 99203.
Correct.
So then for our office visit, established with a high level of medical decision making, what's our code going to be?
99215.
Yep, our 99215. And then that gives us the R55 for that transient loss of consciousness. Yep. Okay. Any questions on that one from anybody? Number 4. So a soccer player hits his head during an indoor game and is admitted to observation to watch for head trauma. The admission date and time is January 21st at 8:12 p.m. with a medically appropriate history and exam and low medical decision making. And then your discharge date and time is, your discharge date and time is going to be January 22nd at 8:15 a.m. Discharge time is 20 minutes. So with that being said, how are we going to report this? So we have our admission date to observation, right, on January 21st. So if we go to our hospital inpatient and observation care services, starts at 99221. And we have a low, no, go ahead.
It definitely wouldn't be that one in my opinion because it says 40 minutes must be met or exceeded.
Well, so with your E&M codes, you can either have time, well, most of them, you can either have a time component or a medical decision-making component. Okay.
Oh.
So with the admission, they tell us that we
So
have a
showing
low medical
low as the
decision
medical
making.
decision.
So what is our
Mhm.
initial hospital inpatient or observation care code for low medical decision making?
99221.
Yep, our 99221. Okay. Should we report the discharge service separately, or is it included in the initial? Yeah, so we should report it separately. So let's go look at our discharge service codes, which are the 99238 and the 99239. And we have a discharge time of 20 minutes.
Oh, that was how I got confused. How dumb of me.
No, you're fine. You're fine. So what's our code for the discharge day management for 20
99238.
minutes? Yep, 99238. Okay. What would happen if, okay, I'm going to back all of this up. What would happen if they were admitted and discharged on the same date, 12 hours apart? So ignore our answer options for a minute. What would happen if we did that? Would we still report the admission or the initial and then our discharge? Would we still report it in the same manner? And have the initial hospital observation services and the discharge day management reported separately?
I'm sorry, I had a distraction. So that's for two separate. You're saying would we report it separately if it was on two separate days?
No, so I changed it.
Oh,
So
okay.
I changed it to where we were admitted at 8:12 in the morning and were discharged on the same day at 8:15 p.m.
Yeah, we would.
So you still want to report it separately with 99221 and 99238?
Yeah.
Okay. So those codes are technically per day codes. So if we were to report 99221 per day and then 99238 per day on the same day, then we want to actually report. There are a range of codes that is, if you look, you have the 2024 manual, it's on page 19. It is hospital inpatient or observation care services, including admission and discharge services. So if it is on the same day and it is greater than 8 hours, then you're going to report your initial hospital, you're going to report 99234 through 99236. That's going to include the admission and the discharge for the same date of service. Okay. So for this scenario, we have same date of service, 12 hours apart. So we can report the combined admission and discharge on the same date. And then we have a low medical decision making and discharge time spent was 20 minutes. So we would just report 99234. Does that make sense?
Why would it? Sorry, I'm a little distracted right now by some things on my computer. Why would it be 99234?
Because we were admitted and discharged on the same date. So if we're admitted and discharged, yeah. So if we're admitted and discharged on the same date of service, and it is at least 8 hours, that's in your guidelines. It's on the second paragraph. No, sorry, your first paragraph. If it is more than 8 hours, you're going to report a single code on the same date of service for the admission and the
Mhm.
discharge. If it's less
Okay.
than 8 hours, then you will only report
Mhm.
your initial hospital inpatient or observation care codes, and you will not report your discharge separately.
Okay.
So that's where you need to make sure that you pay attention to your guidelines whenever you have same day admission. Greater than 8 hours, you're going to use one code for the admission and discharge. Less than
Mhm.
8 hours, you will
Together.
only report the initial and no discharge separately. That makes sense?
Yes.
Okay.
Yes.
I know this can be a little bit of a confusing topic. So I wanted to kind of touch base on that as well. So again, we have our low medical decision making. So I'm going back to the original question so that I don't confuse you guys. Okay. So original question, we have 2 separate days. So our 99221. And then the discharge was 20 minutes on the next day. So like I said, we went back to the original. So we would report 99238 for the discharge on
Mhm.
the separate day. Okay.
Okay.
Any other
Mhm.
questions on that one? I know this can be a little bit of a sticky topic. So I wanted to make sure we had a good scenario to go over this one. Yep, same day, one code, whether it's admission and discharge included or initial only. And then if it's 2 separate days, you're going to have 2 separate codes. Yep. Okay. Number 5. A new patient visits the internal medicine clinic today for diabetes, hypertension, arthritis, and a history of cardiac disease. The provider performs a medically appropriate history and exam. Blood pressure is high and all other conditions are stable. Labs ordered are your HbA1c and your complete blood count or CBC. And the dosage for the blood pressure medication is reviewed and changed. And the patient will follow up in 3 months. So I'm actually going to pull all of this here again real quick so I don't have to type it all out. Okay. So let's get all of this in here. These out. So with this scenario, okay, we have multiple problems. We have some data and we have some risk. So let's look at our number and complexity of problems first. So what are our problems? We have diabetes, hypertension, arthritis, and a history of cardiac disease, right? Blood pressure is high. So is that going to be stable or not stable?
Not stable.
Correct. So we have one chronic condition that is with progression or exacerbated. Okay. We also have diabetes. Is that chronic?
Yes.
Or okay. And then arthritis, is that going to be chronic?
Yes.
Okay. Are the diabetes and the arthritis, are those going to be considered stable or exacerbated? So diabetes and arthritis, we've established that the hypertension has blood pressure that's high and all other conditions are stable. So that's telling us that we have 2 other conditions that are chronic, or diabetes and arthritis, that are considered stable. Okay. So on our, go ahead.
No, just saying then those 2 then you'll be considered stable then?
Mm-hmm.
The-
Yep.
Okay. Gotcha.
Yep. So what is our level of medical decision making for the 1 chronic with a progression or exacerbation and 2 chronic stable? For the number and complexity of problem, what is our level of medical decision making? If you're looking at your chart for your MDM on pages 9 and 10 and your 2024, I believe in 2023 it's 8 and 9. Which box or which row of your number and complexity of problems has 1 chronic illness with an exacerbation or progression, or has 2 stable chronic illnesses?
Moderate.
Yep. So we've got a moderate number and complexity of problems. Okay. So now we're going to look at our data. How many labs did we order?
2.
So if we ordered 2 labs, because we have our HbA1c and the CBC, if we have 2 labs that were ordered, what level of amount and complexity of data do we have?
Moderate.
Okay. For moderate, we have to have 3.
Oh, so it's limited.
Yep. So it's going to be our limited. Does that make sense to everybody?
Mhm.
Okay. Risk of complications. So what is our treatment plan and what is the risk of a complication happening from that? What's our treatment plan? So we're changing the dosage of the blood pressure medication, right? So that's known as your prescription drug management.
Yes, so that's moderate.
So that's going to be moderate. Yep. So what is our overall medical decision making?
Moderate.
Okay. And then we have a new patient visits the internal medicine clinic today. So we know we're going to be a new patient exam, right?
Hmm.
So I know which one it is.
So which one of our 99203 or 99204 has
99204.
a moderate medical decision making?
99204.
Yep. Any
Hmm.
questions on that one? So let's look at number 6. Number 6, we have a 75-year-old established patient sees his regular primary care provider for a physical screening prior to joining a group home. He has no new complaints. Patient has an established diagnosis of cerebral palsy and type 2 diabetes and is currently on his medications. A comprehensive history and exam is performed. The provider counsels the patient on the importance of taking his medication and then gives him a prescription for refills. Blood work was ordered, PPD was done, and the flu vaccination was given. Patient already had a vision exam and there's no abnormal historical facts or findings are noted. So what CPT is reported? So let's look at this from a what type of visit are we doing?
Established.
Okay. So he is an established patient. Are they doing a quote unquote problem oriented exam? Or what is he coming in
A
for?
follow-up.
A follow-up? Okay. Are we there for our physical? Yep, our physical screening. So our physical screening is going to be what's known as an annual wellness visit or a preventative visit. So he's not coming in because he's having a problem that the doctor's having to address, right? He's just coming in for a screening to make sure that he's healthy enough before he goes into that group. Does that make sense?
Mm-hmm.
Okay. So we should not report the established office visit because, again, it's not addressing a specific condition and coming up with a treatment plan for it. He's there just for that physical screening. So it's going to be a preventative medicine visit. Does that make sense?
Wow, that's tricky.
Right. So don't get too hung up on the word established patient just yet. Okay. So let's flip to our preventative medicine visits. If you have the 2024, it's on page 35 and 36. So 35 has your guidelines.
I was
36
just
is your
jumping to
code.
look at those. I was just jumping to look at those codes, and
Yeah,
I'm actually on page 36 right now.
there you go. So it
Bulbs your
does
uncle.
break it down between new patient and established patient. So this is pertinent in the aspect of we need to know whether they're new established for the preventative medicine. Okay. So with the preventative medicine for an established patient, you see that they are organized by age. So a 75-year-old patient that is established having their annual wellness is going to be what code?
99397.
Yep, our 99397.
And Tiffany, do you
Mm-hmm.
think you could go back over the established
Yeah.
patient?
I'm sorry, 9-7.
Because I got hung up on the. I'm sorry, because I got hung up on the established patient. Like, yeah,
Up here, like, so why we're not using established patient?
yeah,
Well, I mean, we are technically using the established patient, but why it's going to be the preventative medicine and not an office visit? Is that what you're saying?
yes.
Okay. So since they are coming in, okay, and they're not addressing a single problem, right? If he came in and said, I'm experiencing these symptoms, or for a follow-up of the blood pressure, or for, whatever it is, right? They're coming in for that screening. So they're not addressing a single problem. They are doing what's known as that preventative medicine. And that is just going to be kind of like, think of it as like just your annual visit, right? You go to your doctor, you get your blood drawn, you get all your levels done. They tell you, make sure that you're taking your medications, do this, do that, whatever. But you're not going in and saying, I have this problem. Let's figure out what's wrong, and then they're going to prescribe a medication to treat that specific problem. That's going to be when you're going to use your outpatient or other office or other outpatient visit.
Okay, thank you. That makes a lot
You're
of
welcome.
sense.
Okay,
Thank you.
good. Yeah. So that's what I like to refer to as your problem-oriented visits, right? Because you're going in for a specific problem versus going in to just say, hey, I want to make sure everything's still good. I'm going to do my vaccinations. I'm going to do my flu vaccine, whatever it is that you get for the year. That's when you typically do your physical screenings. Okay. Any other questions on that one?
I have a question,
Okay.
Tiffany. So basically, when you see a physical screenings, such a type in the documents, that more or less would tell you that it's more for that reason versus if it's saying that it's an office visit. Would you say? Okay.
Yep.
Okay.
Yep. Now, I don't have an example for this one, but let's say, for instance, you come in for your physical screening, but you also have a problem that you want to have addressed. Okay. So the perfect example is mom brings the baby or brings kid in for their preventative for their preventative medicine screenings, right? But while they're there, they say, well, they've been tugging at their ear a lot. We need to kind of see what's going on with that. Okay. That additional exam that they do, as long as they document it correctly, but that additional exam that they do to address the ear, whether it be an ear infection, whatever it is, that's the outcome, then that additional screening, or not screening, that additional exam can be billed separately from your preventative medicine. And you can have an office visit code with it, with a modifier 25, stating that it was significant and separate from the same date of service.
Okay, so you would just add 25 to that particular physical screening.
Yep. So it would be whatever your, so let's say it's a 5-year-old patient, right? So it would be a 99393.
The office visit code.
Yeah, so it would be your 99393 for the preventative medicine that they came in originally for. And then it would be your 99212 or 13, whichever, whatever like documentation you have to support it. It would be your, I'm just going to say a 99212 with a 25 in addition to your preventative medicine visit.
Okay, gotcha. Okay. Yes. Thank you.
Okay, you're welcome. Any other questions? Okay, let's look at number 7. So Mr. Flintstone is seen by his oncologist just 2 days after undergoing extensive testing for sudden onset of petechia, night sweats, swollen glands, and weakness. After a brief review of the history, Dr. B. Marrow re-examines Mr. Flintstone, and the exam is documented, and the medical decision-making is of moderate complexity and takes 11 minutes. The oncology spends an additional 45 minutes discussing Mr. Flintstone's new diagnosis of Hodgkin's lymphoma and treatment options and prognosis. So what codes are we going to report? So we know that they're there for an office visit, right? So he's there for a problem, because he's there for the sudden onset of petechia, night sweat, swollen glands, and weakness. So we know that that's going to be an office visit. Is he going to be new or established?
Established.
Right. So we're going to rule out 99204. And then 99253, this is not a consultation. So we'll rule out that one. Okay. So we know that 99215 is going to be our E&M code, right? So 99215, we have a high level of medical decision making. And then what's our time component for 99215?
45 minutes.
Okay. No, for the 99215 is what? No, you're fine.
Okay, yeah, 11 minutes. I'm sorry.
No, for the 99215, our time component is 40 minutes.
Oh, 40 minutes? Oh,
Yeah.
okay. Okay, I see it now. Okay.
But for our visit today, we had 11 minutes and an additional 45 minutes. So how many minutes does that give us total?
Okay.
So 11 plus 45 is what?
56.
Yep. So we have 56 total minutes. So underneath our 99215, what does our parenthetical statement say directly underneath 99215? Right above the, go ahead.
Oh, it says for services 55 minutes or longer. You use long surface code 99417.
Yep. So since we have over 55 minutes, we can use a prolonged service to let us know that they have met and exceeded the 40 minutes to 55 minutes, and we can use an additional code to make sure that the provider gets paid for their additional time, right? So 99417, let's flip to 99417. And that code description is a prolonged outpatient evaluation and management service time with or without direct patient contact beyond the required time of your primary service. When that primary service level has been selected using total time, each 15 minutes of total time. So over and above the 40 to 55 minutes, we have that additional 1 minute that they can get paid for. So we're going to use our 99215 and then the 99417 to make sure that they get paid for the additional time.
And you can only use that 99417 along with that 99215, correct?
Correct. Yeah. You should never use 99417 with a 99214, 99213, or 99212.
Okay.
Yep. Because if you have 99214 and you've exceeded that time, then it's going to automatically bump it up to a 99215, right?
Yeah.
So that's just the key thing to remember with your 99417 or 99418, whichever type of prolonged care we're using. Never use it for a lower amount of your E&M code. It should always be the highest level in that category.
Yeah, and luckily it says it here. For prolonged services, it says how to use these codes, and like before it.
Yes,
I was just
it
letting
gives you.
know.
It gives you the specific codes that you can use it for. But I know a lot of people. There might be a scenario where it says that they, spent. I don't know. Like it gives you the medical decision making of moderate, but it doesn't tell you like additional time, right? And it just tells you a total of 56 minutes. So a lot of people will take that and just bump it up to 99214 and then use the 99417 for the additional time. So, but yes, make sure that you're paying attention to all of your parenthetical notes to make sure that you are using the correct code with your prolonged care code. So don't ever use that 99417 with a lower level. It should only be a 99205, 99215, so on and so forth. Okay. Any questions on that one?
No, thanks for explaining that.
Yeah, of course. Yes. Of course. So there are 3 more questions. Okay. We obviously did not get to them tonight, but they are out there for you guys to go look at and practice. And then the answer keys down here at the bottom, as always. I don't want to get into another one and then us have to rush through it. But any questions on E&M in general for the last 3 minutes that we've got?
Yes, I do, and I'll just make this quick. So for preventative treatments, I just wanted to ask, would an example be if you go in and the child is having symptoms of something and then they take preventative measures like let's say they might have symptoms of COVID or something, and they just diagnose pain medications or something so would that be considered preventative treatment?
No, that would be your problem-oriented office visit. So just your new or established office visit. Preventative medicine is if they are not coming in with a complaint, period.
Okay.
They are just coming in for that yearly checkup.
Okay. Thank you.
You're welcome. Yeah, that was a good question.
Makes sense. Yeah, it was a very good question.
Okay. Any other questions? You all had some. I was expecting a lot of questions tonight with E&M, just because E&M is a beast and there's a lot of different moving parts.
Yeah, I'm gonna definitely review this video again. Yes, but it was very helpful.
Good. If you all need anything, as always, put your questions in the Discord chat. Anything along those lines. If you have any questions that you think of. Next week, we are going to start all over. Okay, because I know there's a lot of people that kind of have been joining and all of that kind of stuff. So next week we are going to start all over brand new with ICD-10. Okay.
Okay.
So,
Yeah.
all of the questions, I haven't decided if I'm going to recycle questions or if I'm going to make new ones. But if I do make new ones, then there will be an additional folder in the OneDrive. If not, then we'll just use the same questions. But like I said, I haven't decided if I'm going to recycle them because, like I said, I know a lot of the people that are here at the end were not here at the beginning. So it's not going to be a repeat of all of the material. But
Okay.
if you guys have any questions, let me know. If not, then I will chat with you guys next week.
Thank you, Tiffany. as
You are
always.
very welcome. Absolutely. I will talk to you soon.
So another question, Tiffany, I have is, let's say when I do finish my study guide and I start taking the practice exams, what are you going to do what will happen if I just keep failing them again and again?
We'll
'Cause I
cross
wanna-
that bridge. We'll cross that bridge when we get to it.
Thank you.
If we
Yeah, I'm
get
just
to
glad.
it.
I'm
Yeah.
really thankful for this new job that I'm not, because I'm only 3 days in, or 2 days. I started on Monday, and I'm really happy to be there. So there's a part of me that doesn't really feel rushed to take the certification exam.
Yeah. Yeah. Don't rush yourself. If you're not ready for it, you're not ready for it. But if you do get through your study guide and you're still not comprehending it, then we'll like I said, we'll just cross that bridge whenever it comes to it. If you
Like,
do
you
your
want me to,
practice
like-
exams.
Like, you want me to private message you if that happens?
Yeah, that's fine.
Thank you. Good night, Tiffany. You are awesome.
Thank you. Taylor, I do CRC. With the legacy program, we do have a CPB program, but I do not have my CPB certification. So Rachel's the one that does the CPB. But I do have CRC and I do have that course available. Is that what you're asking?
Yes.
Okay. Yeah. If you want to shoot me a message, we can talk more about it.
Okay. Thank you.
Okay. You're welcome. Have a good night.